Welcome everybody to today's session. Today's session is really more about a conversation. We asked folks to go back into your groups over the last couple of weeks and think about some of the payment models that we've been discussing, and talk amongst yourselves to consider what the impact of those particular payment models might be on your sort of clinical and financial operations back at your respective organizations. So we really appreciate the fact. We know this is a crazy week for folks because of the holiday, and we know we have one group for sure that's missing today because of that. But our goal today really is to do just kind of an active conversation. We've got all three Starlings on the line today: Andrew, Samantha, and myself. And really what we want to do is just kind of facilitate this discussion and see what you came up with. So just as a quick reminder, we're going to do a quick teeing up of some of the core concepts that were in the case study, and then we're going to do some sharing out for a while and then wrap up, because believe it or not, the session on December 5th is our last one, and we'll also be hearing from groups at that meeting as well. So this particular case study was really an exercise in asking you folks to take a look at some of those common models of emerging payment and think about what the relative risks and benefits of those models might be. We know that, despite everything that's been going on with the election and all the craziness and uncertainty that brings, I think most of us who work in this field don't anticipate monumental shifts in the way that some of these models have been implemented. And we know that there is, it's possible that if you aren't already working within some of these payment constructs, it's going to be something that you're going to be taking a look at and exploring over the next couple of years. And it's also critical to understand, and I think we spent quite a bit of time talking about this over the last three sessions, that these models of reimbursement really do ask new things of us as it relates to our internal competencies, the type of infrastructure we need to have, which ranges from everything from the type of staff and care team models that we put in place to the types of sort of, all the plumbing around our IT and information systems. So we want to do, just before we jump in, just a little bit of a quick reminder. This is actually something that you guys saw very early in our sessions together, way back when in September, I think. Just a quick overview of the main accountable care models of reimbursement, for 5 of which we're going to discuss today. So just a reminder that as safety net providers, payers of healthcare are really going to be asking you to demonstrate your value under these new models, and that as we move up the trajectory from what has traditionally been for many of us our typical bread and butter reimbursement model of cost-based reimbursement, all the way up to full capitation, all along the way we're taking on incrementally more risk, financial risk, and having to build our competencies along, as we're becoming more sophisticated. We like to sort of let folks know that, the pay-for-performance models and the shared savings models, we really view those as transitional models to the more advanced models of payment, things like global payments and the various capitation models. Most of the time with pay-for-performance and shared savings, just as a reminder, your base payments typically will stay intact. So if you're getting cost-based reimbursement now and you enter into contracts that look at pay-for-performance or shared savings options, typically your cost-based, your fundamental reimbursement stays the same. But really, once you get into the global payments and the capitation models, those things start to fall away. As you go up this trajectory toward full capitation, you take on increasingly more risk, financial risk, but ultimately the models are sort of predicated on this idea that the trade-off for that is that you get potentially more reward opportunity for gain sharing that comes back to you in a level that wouldn't have been possible in some of the other models. So let me just stop there and see if there's any questions. I know I've got both Sam and Andy on the line. If there's anything else you guys want to add as we jump in to do a quick review of some of these models. Or any questions from the group?
Hi, Denise. I have an appointment scheduled tomorrow for an intervaginal ultrasound, and unfortunately I got word from my insurance company that they're not going to pay, so I need to talk to my PCP and postpone. S-H-A-R-G-O, Shargo. Darcy, D-A-R-C-Y.
So it sounds like we've got somebody, Darcy, we can actually hear you, so you might want to mute your line. Anybody else have any questions before we move into okay. All right, so the most fundamental model of payment change that we see, really many folks started in on this road well before the Accountable Care Act really took root in all of our worlds. But this idea of pay for performance, which essentially provides financial incentives for the achievement of specific outcomes. And those outcomes can vary from things that are almost transactional in nature, like making sure that everybody comes in for an annual well visit, to achieving on various quality and other performance metrics. When we think about the type of competency and infrastructure that we're going to need in order to effectively maneuver under this model, it's things like quality reporting, data benchmarking, and to some degree population health management. The example that we use here is the state of Iowa ACO program for its Medicaid program has a value index score that determines the payment of a bonus to providers participating in an ACO. And it is actually what it is a composite score based on how well that total network does as it engages with a distinct population of chronically ill patients. And there are some specific markers that they look at in order to pass along those pay-for-performance payments back, along with things that include adult wellness visits and unnecessary utilization, emergency department utilization. So they're looking both at, your historical performance as well as making sure you hit some of those markers along the way that would trigger additional pay for performance. The shared savings model is really an opportunity to receive a portion of any money saved against a target budget. So in the case of a shared savings model, what you have is a baseline year or baseline years that are set out that look at both quality and cost performance. And then based on how well you do relative to those targets, a percentage of that shared savings comes back to you. It's a little different in that it requires that the participants have an understanding of total cost of care, that they've got the ability to identify strategies that reduce waste or redundancy in the system, largely typically driven by, being informed by what claims data is telling folks, and then being able to set up care coordination and collaborations across provider types. So the safety net example that we've got here is the state of Vermont Medicaid ACO shared savings pilot provides an opportunity for up to 50% of any of the savings generated by the ACO to be passed back to the providers that participate in that ACO. They are required to meet certain quality scores in order to be eligible to receive those payments in the first place. So we've got a link there to more information on that. Does anyone have any questions so far? Okay. The next model is global payments, and this is one that we don't see a lot of safety net providers engaging in too much, but there are some specific places where global payments start to make sense. And a global payment is a defined payment for a specific set of services for a specific patient for a very specific period of time. And the example that we typically use in this is prenatal care is often an example that the safety net will engage around global payments. So you've got, a pregnant woman and a defined a defined dollar amount that the provider needs to manage her care within. So you've got what you've got for that patient, and it's really up to the provider to manage the clinical care and the cost of that clinical care to support that pregnant woman. It requires care coordination, the ability to impanel those patients that are targeted for that bundled payment, some degree of risk scoring and stratification so that appropriate care coordination can take place based on what the needs of that patient are, and then some specific strategies around patient activation and patient engagement. The example we provide for this is that CMS provides a bundled payment for care improvement, the VCPI initiative, which some of you may be aware of, and it rewards providers that can improve the cost effectiveness and quality of outcomes within a set of 48 bundles. So there's information at this website that we've provided the link to here where you can see different what those different bundles might be. Any questions on this? Okay, the next example is partial capitation. And this is where you see payers providing back to providers or groups of providers a single payment made for a defined group of patients for a specific set of services. Where we see this sometimes is with primary care. So there's a couple of examples within the safety net where primary care capitation is being tested. In this situation, it's really important that the providers that engage in this model really understand the basic constructs of how to eke out as much cost efficiency as possible within their models. The nice thing about primary care capitation and capitation in general is it gives providers a lot of flexibility in how they provide services and how they reach out to their patients. So telehealth and other types of asynchronous care models or care models that rely on physician extenders and other types of care managers are highly advantaged in this because the typical payment models are sort of suspended in order to be able to help support activities, in this case, around primary care that are going to best serve that patient. The California Primary Care Association is testing out a pilot that the state has to capitate, their traditional health center payments and instead pay them on a per member per month basis to provide those primary care services. Any questions on this or anything that anybody else wants to add? Okay, great. And then the last model that we're going to talk about today is full capitation. And this is where a single payment is made for a defined group of patients for all covered services. And so this is the one that is really ultimately gives you the most flexibility as a provider to really think about the best way to provide those services to the defined patient population, but also creates a lot of potential risk for providers who may not be quite ready to take the step. When it comes to things like full capitation, we very rarely will see groups do this on their own. Typically, in order to be able to do this effectively and manage the risk pool, we're really looking at groups of patients in excess of 20 to 25,000 patients. That means you have to have a lot of internal systems up and running in order to be able to really effectively, properly identify risk stratification tools that will allow you to support interventions that are going to best meet the needs of the patient. And as we've indicated here, it's also critical that organizations and providers participating in full capitation really understand what cost effectiveness is and how to really identify and manage total cost of care. The state of Illinois, and this is actually a model that has changed, so we probably need to update this a little bit, but initially the state of Illinois, and I'm sure that Lutheran Social Services, if they're on the line, is more than familiar with all the changes that have happened in the Illinois state Medicaid program over the last 3 years. But initially had this goal that 50% of all Medicaid clients would be enrolled in private managed care by 2015. And that included provisions that the clients be fully capitated in financial arrangements with these managed care entities. Some of those managed care entities were insurance plans, but others were networks of providers at the time that were called like coordinated care entities. They've since had to modify this model, and I think it's important to understand why. In part, it was because the level of sophistication and infrastructure that was necessary for both payers and provider organizations like ACOs or CCEs to take on this level of sophistication, the ramping up period was really too fast, and it was too hard to get folks all aligned in that way. But it really does show that states are looking to move quickly into thinking about how to really move the needle on the cost outcome. Any questions or thoughts about that? Okay, so now what we're going to do is we're going to break into our discussion with all of you. Hopefully you all had time to go back and think about the discussion questions that we're going to talk about as we go model by model through today's discussion. And you'll remember that we wanted to get some feedback from each of you on what you thought the strengths that your clinical practice had in dealing with the particular model that you were assigned. Where did you think your weaknesses or challenges might lie, and what opportunities actually does the model present? When you think about what kind of competency you might need to build, and remember the last two sessions, pardon me, really focused on, creating a budget and an infrastructure to help support some of this. What did you think, when you thought about how the model applied back to your practice, what did you think you were going to need in terms of infrastructure? What are some of the scary things about this model? Some of these models really represent a pretty significant paradigm shift. And so how does that really put your practice in kind of a defensive posture? And then have you been presented with the model yet? And if you have, how was it presented, who presented it, and what's the impact been? So we're going to start with pay for performance. And I'm hoping that there's somebody on the line from the Maine Primary Care Association that can kind of share with us your thoughts on this.
Hi, it's just me today, unfortunately, and I've had staff out sick. So, I'm wondering if it might be possible for me to go last. I'm still waiting through everyone's emails from over the weekend, because I put up these discussion questions to my team, and then 2 of them were out sick, so I didn't have a chance to actually do a good job of crosswalking to your specific question. So I have something to share. I just need a little bit more time to organize my thoughts.
Oh, no problem. So let's move on then. Yeah, no problem. So let's move on then to the Long Island FQHC and Mary Center, and we'll talk a little bit about shared savings.
Hi, can you hear me?
We sure can.
Oh, this is Josephine from Mary Center. I can take a stab at it, so I can briefly go over what we're looking at. We're looking at the model where we have some shared savings incentive program, and we're dealing with one of our MCOs, and we came up with a thought process to come up with this incentive plan for reimbursements based on the outcomes. We have identified about 7 different outcomes, and they are basically, I have this, diabetes, their access to care, the adult access to care, lead screening, well child visits, children access to care, annual dental visits, and adolescent well care. And we're coming out with a baseline based on the information from the payer system of where we are at the start of the baseline, and then we'll be evaluated on a yearly basis on how we met those particular baselines. And the providers will be paid an incentive based on that baseline that we've identified. Some of the strengths that we have with this process that we're looking at is that we do have a close relationship with this payer and working with them on a lot of our outcomes and trying to get information from them. One of the weaknesses that we have is we are developing that the system where ad hoc system where we can get ad hoc reports from them, where we can get the actual membership basis and the utilization on how their outcomes are actually being monitored, and do we have good measures with that. So that infrastructure, we're still working on building that to make sure that we are getting adequate information and have a way where the providers can go out there as well and monitor their progress on an ongoing basis. So when we get the reports back from them, we can actually do a comparison to make sure that the calculation of the incentive is adequate. We also, that will be ad hoc reports and looking at having access to their electronic portal. So how's the model threatening? It's kind of threatening if from the shared cost point, if we don't meet these measurements, and if we don't have the infrastructure built in place, that could be a cost to us. But as far as the strength part of that, we will still get paid the fee for services. We are looking at leaving that process in place. As far as in the district, we have a set amount that we're being reimbursed with the contract from this MCO, and we do have a RAP payment, so we will be still getting that RAP payment with the model. So overall, that's what the direction that we're going and what we're looking at, and having a fee for schedule and a shared savings module.
Yeah, and I think you bring up a really good point too, which is that, and one of the reasons that we think that a shared savings model is a good one for safety net providers to think about is that it allows them to really start taking on some of these more advanced care coordination models. It really gets them thinking about how to do risk stratification together with other groups of providers, but it does protect those base payments, at least initially. And many times when we see groups that enter into programs like the one that the district is taking on or the Medicare Shared Savings Program, providers will often have the opportunity to decide whether they want in the beginning to only take upside risk or if they want to do both upside and downside risk. And I can't remember how many cycles deep we are into the Medicare Shared Savings Program, but even as late as this year's application period for the 2017 year, that was still an option for providers. And when those upside-only risk opportunities are presented, we think it's really a worthwhile endeavor for groups to take a look at how they participate in that. Now, that doesn't mean there's no financial impact. Often you'll have to spend a little bit of money and direct some resources to get some of that infrastructure in place, but it really allows you to be looking at how to test out some of these more advanced models of risk stratification and care coordination while still being protected by, with your existing base payment. One caveat to that is we think we're going to see CMS move, and if CMS is likely to move this direction, I think the states are likely to move this direction as well with programs that look at Medicaid ACOs and shared savings programs, they're likely to start putting pressure on provider groups to take on more downside risk. So, but I think, you bring up a really excellent point in terms of, being able to protect those payments through your existing encounter-based reimbursement and even potentially some kind of a wrap payment. Andy or Samantha or anybody else have questions on this? I'd be curious to see. I know we've got lots of diversity on the call, and even if you weren't assigned to this particular payment model, we'd love to hear from you about whether or not you've been confronted with this and kind of what the impact has been.
This is Darcy in Maine. We have, I think it's we're going into our third year with a Medicare shared savings with 10 of our FQHCs, and I think the initial frustration from at least from the health center perspective, was that they were already doing a lot of squeezing in terms of savings in the system, and so they felt like they had to work especially hard. Not that they weren't willing, but that they were really digging and had to really focus in order to meet some of the savings targets, because the health centers are really already kind of oriented that way and have achieved savings without the pressure of a formal shared savings program. Having said that, we have seen improvements in both cost and quality, and this is, again, Medicare, so it's just the aged population and disabled at our health centers. So I think there was some initial frustration and sort of questioning about whether or not they were going to be able to achieve savings, and they're definitely headed in the right direction. So it's just taken longer, I think, ultimately, than the health centers had probably hoped for.
Yeah, that's a really good point, and I think that's also why, we talk about the shared savings model as being one that's transitional, because there does come a point where there's only so much you can do with a particular patient population, and, particularly since, providers don't control everything that their attributed patients choose to do. No, but I think that's definitely a good point, and I think that it's, most groups have seen benefits under that program, but if you were already working together well and had some tools in place to effectively manage these populations, it absolutely makes it challenging, but I think that's a really, really good point. Anyone else want to add anything or have any questions before we move on? And I understand that Long Island isn't on the line today, so we'll just Okay, so now we've got Lutheran Social Services to talk with us a little bit about the thinking that you did around the partial capitation model.
Yeah, good morning, everyone.
Good morning.
We looked at an initiative that is coming our way. So we've been doing a pay for performance. Again, I should reiterate, we're a behavioral health safety net provider, not affiliated at all with a medical system. So we've been working with sort of pay for performance, helping insurance plans to meet the 7-day follow-up from inpatient psychiatric placement and meeting that 7-day follow-up measure. And that's been working very well. And some peers now are coming toward us to look at how can we impact a longer-term model for the moderate to high-risk folks in their plans who end up having some intensive costs for the health plan. And we're working with them to try to, based on their risk metrics that they go through, how can LSSI engage in a second plan to kind of contract to help them with those high utilizers. So it's very similar, we think, as to this partial capitation model, where we'd be working with this defined group for the defined behavioral health population. So where we think we are in terms of our strengths is that this type of model is very aligned with our agency mission to serve a whole person and to treat, do whole person care. It's really aligned with our strategic plan, which we just came out of a 3-year strategic plan. And it really is aligned with the goals of the payers. We've been monitoring that very closely for a couple of years as we've been going through these processes. So we believe that our alignment is really good. We're also building upon what we do well with care approaches that we know are effective. And we have a continuum of care we're in the northwest side of Chicago. It's a pretty big geographic area with a pretty large population. And so we have a network of our own services that we can provide that are an extension of post-hospital care. It's the type of services that our payers want to lead their clients, their members, too. The other strength is that we can attain our volume really by working with multiple payers. So we can start with one payer, but then quickly as that model begins to show some success, then we can bring on other payers. So we could take a smaller subset of payers' pain points, their high utilizing population, we actually gain the volume across payers. So our challenges certainly is what's outside of that capitated amount is really outside of our control. And it really impacts our success. And so that's really something we're wrestling with now as we're trying to put together this proposal and move into this partial capitation. So we're held accountable, but as you kind of pointed out, Illinois is a bit of a fragmented system. We have multiple payers in play, some of which are maybe moving out of being a payer in Illinois because Illinois tends to cycle and uses sort of a reapplication process to narrow down the number of payers in the system. That's one of our big challenges, and also geography. Geography can be a major challenge when you have, it's an urban population, and so people really get placed in multiple areas of the city and return to the opposite end of the world. And so being able to stretch our internal resources and know the same resources on the south side of Chicago versus the north side of Chicago is really pretty much a challenge for us. And then just building our teams, our internal resources, staffing is a challenge to go, what is the right size to do the work that needs to be done? Our opportunities, we really believe, is this is a good foundation for us in terms of taking on more value-based work and building upon any successes that we have. We believe also Illinois has some pretty restrictive Medicaid plans, and those plans are different whether you have a mental health population or a substance use population. And so for those that are comorbid, it's really hard to work with the folks because you're operating under two different sets of funded services. So that alignment really, is a bit of a problem for us. And so having an ability to get a per member per month and just provide the services that the individual really needs is a big benefit for us. It also allows us to really co-create the services with the payer, so we have really robust conversations with them about what their needs are and what we provide and how we can maybe align those things with their goals. In terms of what we are looking at in terms of our additional competencies or the infrastructure that we need, we really need to be able to accept utilization data. So we've made requests that we can get raw utilization data and claims data so that we can really begin to understand the populations that they're asking us to serve. So again, these are really high-risk, high-complexity folks, but we also need to know their health data because that's going to be a part of what is a barrier for them to continue on with their behavioral health. So it's getting that data and then we would not have the internal resources to do that, so we would be contracting out for an entity to be able to do that, and to really also then build our own sort of learning. And what is it that when you're looking at claims data, what is the knowledge base that we want to have, and what requests really would we have around the data. And then we have to build, like I said before, we need to build our care coordination and utilization staff. We have really good staff on board, but we're really borrowing from our own clinical management team and our quality improvement team and our managed care team to be able to put all this together. And then we know that that is not a sustainable plan, and so it would be having to really grow our ability to work more aggressively in this area. And then we really need to look at our EHR software is a really great one, but does it really accommodate a PMPM type payment when it's structured around a fee-for-service payment, and how much can you tweak the system to be able to manage what you can do, and then just having to pay for that even, as well as a special custom-built report or custom-built unit that we would have to purchase. And then I think sort of finally, just again, it kind of goes back to that, how can we pull the data that we have, or how can we partner with our payer system to be able to get the correct reports, to look at patient outcomes, to continue to do our financial forecasting. So it really goes back to access to data and then being able to manipulate that data to our advantage. And then in terms of how we find the model to be threatening, I think the biggest concern is really making the shift. How do you make a shift in your own financial forecasting, in your own clinical staff, and your own management staff when it's been based on fee-for-service for decades, and then having to shift accordingly around to a value-based methodology. So we're working really hard in terms of orientation, but then working through the details of how to forecast, or working through the details of clinical staffing patterns is really where you're going to win or lose, and so we're just really aware of that. We're also, again, large urban area, and so competition in the area is a concern. And I think it comes from both sides in terms of how clients can choose to stay with providers, and the ability of those providers, or the willingness of those providers to really collaborate with us is their choice. And so there is a certain sense in the marketplace is that you're building, in a network of providers where you may or may not be able to get the collaboration that you need to be able to effectively track where your client population is going. And then finally, I think it's really, we've experienced a little contract drift. And so on good and on positive and negative levels, payers like data, and they see trends, and they want either more, or they're asking for things that you're not necessarily contracted for. And we've also have build up and toward a contract in the past, and then that contract drops. Like there's a management team decision that you're 4 days from go live, and then they change their mind. So that is certainly threatening when you're taking on the risk of building all that, all the startup costs, and working through all those negotiations. And in the end, that's all been work on your part that has not really taken off. So that's where we're at with partial capitation.
I mean, I think you guys have done a really good job in really thinking through how, with as much uncertainty as is out there with the payers, how you can really think about sort of targeting those resources for those high-risk patients. And I think that, the work that you guys are doing around behavioral health and looking at some of these issues is really on the leading edge of what's happening. We see a little bit of this happening in other parts of the country, but I think it's a really interesting model, and are just really encouraged to hear that you guys are spending so much time thinking through kind of the structural elements and things that need to happen. So does anybody have any questions for Lutheran Social Services? Because I think they've really shared a lot of kind of how this fits in with some of what they're doing, and I'd just be curious as to how other folks are reacting or things that you're having to respond to in your marketplace, any thoughts or questions you might have for them. Okay. Anything else before we want to move on?
Amanda, this is Sam. Can you hear me?
We can.
Okay. I thought I might share just another example from California. Starling works with the California Primary Care Association, and Amanda and I actually both used to work with them as well. And so, Amanda, you mentioned earlier the payment reform pilot that the Primary Care Association and several health centers in California are working on in partnership with the State Department of Healthcare Services, where the model is going to cap the PPS rate. And just one piece about, I think it might be interesting for the group to hear kind of how a statewide partial cap program is rolling out from the readiness perspective, because one thing CPCA realized, we spent several years sort of negotiating and pushing for the opportunity to roll out a statewide payment reform initiative, and then we spent a lot of time sort of on the mathematical and actuarial end of building the payment model. And once that, and working through the state plan amendment with the Department of Healthcare Services, and once that process was moving, the Primary Care Association realized from a readiness perspective that we needed to, as much time as you spend on sort of doing the mathematical calculations on the payment model, what will work out, you also, health centers needed to do as much work on the training and readiness end so that when the payment model shifts, they're ready to sort of make the most of the opportunity. You can't, we spent a lot of time talking to the Oregon Primary Care Association, who had done a similar payment reform effort, but with a much smaller population, maybe a friendlier state government. And so we realized going into the reform initiative that if the health centers who are participating in the pilot weren't ready to capitalize on the model from day one, that they wouldn't be able to demonstrate their success in a way that was that would sort of leverage the opportunity to the greatest degree. And one way that CPCA and the pilot health centers have done that is they worked on making sure that they were able to control their data. And so they did for all the pilot sites that are opting into the pilot, they've done standardized assessments. They've looked at sort of where gaps exist that are standard across the cohort, so that the PCA can offer training now in the ramp-up period, so that when the payment reform pilot actually begins, folks have addressed team-based care issues or data management issues or gaps in behavioral health, so that all the health centers who will go into the pilot, they'll be sort of functioning in the model already and prepared to do that, so that in the short term where the success of the pilot is being evaluated, they won't have as much of a ramp-up period, because they had, in previous payment reform efforts, you switch and then you spend 8 months sort of figuring out how to function in the new normal. And when budgets are as tight as we're all facing, you don't have that kind of padding. So just, when you're looking at working in these models, I think one important piece about sort of the balancing these, what are your weaknesses and what opportunities does the model present? It's really important to think about readiness and how to be as prepared as possible going in, and what sort of prep work you need to do in advance of actually facing a different financial reality.
Thanks, Sam. And I think it's important to, also keep in mind that, they, in that particular example that Sam just shared, that was the FQHCs and health centers, and they're really part of the goal, I think, of that preparedness effort. Even the preparedness effort was rolled out on a pilot level because it was, kind of understood that, certain counties of the state were going to be looking at implementation a little bit faster. And so the idea then being that the learnings from even some of those preparedness efforts could then be shared back out. So it is really important, I think, as a field within the safety net, that we continue to talk to each other about, kind of what some of the landmines are in some of these more advanced models, and where can we identify really effective and efficient ways to work together. Andy, anything you want to add on primary care cap before we move on to full capitation?
Just, I guess, from a financial standpoint, what we're seeing is it creates a real opportunity to be more flexible because the money comes up front, and and because it allows for really you to staff very specifically to the needs of the population. On the downside, it is a fairly, or at least usually does contain one of the higher levels of financial risk. So if that money isn't adequate to cover those services, you got to keep continuing to provide services, even though there's no additional incremental investment. So that really, kind of indicates or lays out the financial challenge associated with those models.
Thanks. And then the next discussion is around full capitation. And we've got North Carolina and New Hampshire, hopefully, on the line to help talk about this. Does somebody want to go first?
Hey, this is Robert from the North Carolina Office of Rural Health. We can go first. So we had the full capitated model, and just before we begin, just disclaimer: our office doesn't actually run any sites around the state. We provide funding and technical assistance, but it is from the perspective of a rural safety net practice. So some of the strengths of a fully capitated model for our site. So some of the things that we've learned through these presentations and research is that clinical efficiency is really critical if you want to succeed under a fully capitated model. So at our sites, most of our practices in rural North Carolina are already exceeding certain HEDIS benchmark standards for quality, and many of our sites are already PCMH recognized or striving for that, which can potentially be an indicator of clinical efficiency. Some of the weaknesses that our sites might have, we really don't have a lot of population health analytics tools or the expertise in those clinics to use such tools. All of our sites are not connected to our health information exchange and aren't using their EHR to their full capacity. There's a large need for workforce education if we wanted to do a fully capitated model. We don't have remote patient monitoring currently if we were going to do a fully capitated model, which is something that you would need. And then the associated cost with improving clinical infrastructure would be quite a heavy lift for our sites. What opportunities does the model present? So if our patient population can be made more well or less sick, there's an opportunity for increased savings depending on the negotiated capitated rate. I think overall for rural safety net providers that we work with, there might not be a lot of opportunities under a fully capitated system. Let's see. What additional competencies and infrastructure would we need? A lot of it is professional services that our sites don't have right now. So we would need actuarial support, access to population health analytics and predictive modeling. a lot of legal consultation, including health law expertise, maybe consultation around stop-loss insurance if we're under a fully capitated model. We would need access for advanced claims utilization, and we would need to get all our sites connected to the HIE, so HIE expertise, which is progressing in North Carolina. How is the model threatening? So if the attributed patient population is more unwell or sick than anticipated, the potential for not meeting the capitated rate would be very, very high. Sites that we work with don't have a lot of experience negotiating payer contracts. Again, they don't have in-house legal counsel, anything like that. So they would need something like that to help them with any unforeseen challenges or issues. Let's see, the last one under this, substantial financial resources would be needed to assure that the deal is good, the capitated rate is good. Most of these resources would be in the form of grants, since most of the sites we work with, they're relatively small. Let's see. And have we been presented with this model yet? No, we have not been presented with a fully capitated model yet. Did I miss any questions? All right, thank you.
Thank you. How about some feedback from New Hampshire?
Okay, thank you. This is Greg Vassy with the Hospital Association and the Rural Health Coalition, and I'm broadcasting from New London Hospital, and the Vice President of the New London Medical Group is with me, but I'm not sure of any other of our participating hospitals who are on the line today, but I certainly want to invite them to jump in if I say something that they would like to expand upon or dispute. But I think the first disclaimer is that we don't have, among our critical access hospitals in New Hampshire, we don't have any fully capitated model, nor do we have anybody who has offered it yet. So that we are dealing in the realm of the hypothetical and can't really share any of our actual experiences with payers. But we started off a little bit differently in terms of looking at indicators of our financial readiness at the hospital, critical access hospital, and affiliated medical group levels. And of course, we want to look at the efficiency and the effectiveness of our existing revenue cycle indicators, and we all pretty much know what those are. But we have to have that ship in order before we jump to another level of financial risk. We also have to look at the ability to generate reserves to fund the infrastructure that will have to be expanded for full cap, and the anticipated delayed reimbursement cycles which come along with these programs. And where we look for that ability to generate reserves is not always going to be to our own bottom lines. It would be nice if the reserves were there from operations, but the greater likelihood is that we're going to have to look at grants and more likely corporate consolidations with larger organizations. And that certainly is what we see happening in New Hampshire at this point. We also have to look at our provider contracts. All of the critical access hospitals in New Hampshire have significant numbers of physicians who are employees, but their employment contracts are going to have to reflect the variation that might come into play based on their performance against cost and or quality metrics. And finally, it's not finally, but in this particular category, is full capitation going to be a business opportunity, or is it really just a matter of survival? I think for most safety net hospitals, they are sole community providers. There is no new market share that's going to come their way as a result of participating in a full cap model. It's really going to be more a situation of hanging on to the population that is currently being served. After a full cap model is implemented, the kinds of indicators that we would be tracking would have to do with population health analytics from both our claims analyses, but also reflecting predictive analytics as well. And there is definitely the need for a health information exchange so that we would have full data on the medical experience of our impaneled population. The ability to risk stratify is, as we've heard from many of the presentations, is extremely important. And we need to be looking at the capability to build alerts into our systems so that alerts can be generated both to the provider as well as back to the patient that certain actions need to be taken. Metrics that we need to be looking at once we're under a full cap model. We need to be looking at baselines and our trends for high cost outcomes, whether these are readmissions to the hospital, readmissions to the emergency department, hospital-acquired infections, and diagnostic-specific readmissions, particularly among the chronically ill. I think that the other piece indicators that we need to be tracking post-implementation is our ability to look at what over the short term are fixed expenses. In many of the models that we have reviewed in the course of these presentations, these sessions, we've looked at the opportunity for savings that might be forthcoming if we were able to keep psychiatric patients fewer days on med-surg units because there was facilitated access to psychiatric hospitals, or if we were able to avoid a readmission or keep people out of the hospital. Those are real savings, but they materialize over a long period of time. They're not available to us immediately at the time the capitated payments would be enforced. And that really goes back to the point about being able to generate reserves or partnerships to fund our ability to sustain ourselves while we really adjust to the new metrics and the new requirements of a capitated system. In terms of being able to forecast our gains and losses, we're looking at population analytics, quality metrics, the trends, and if we're truly under a full capitation system, we really need actuarial assistance along with a fully developed health information exchange so that we can monitor the full cost of caring for the population that is impaneled to us. The strengths and weaknesses of our clinical practices. First of all, we do have a high percentage of employed providers, and therefore we do have the ability to, hypothetically at least, to structure incentive-driven compensation models that can sustain, support the metrics that we need to meet to be able to survive under the full capitated model. Quality, care coordination, alternative delivery models, all of those things can be implemented in accordance with what the needs of our financial arrangement is. We don't have to necessarily be negotiating with individual providers, again, because we have a high percentage of them under employment. The weaknesses, as safety net hospitals, critical access hospitals lack control really over some of the highest cost interventions that the population can experience. For example, thoracic surgery or acute rehabilitation services, long-term psychiatric hospitalization. we have to look to tertiary care facilities, others, to provide those services back to us so that it further adds risk to our financial model. Opportunities presented by the full capitation model. I think there are a lot of question marks after that statement. If we look at it from 20,000 feet or 30,000 feet, certainly we think that population health ultimately does benefit from a fully capitated model, but ultimately it's going to be a matter of retaining our market and avoiding the loss of patients to other providers who may find a way to exist within the full capitation. Additional competencies that we need: certainly care coordination for the high-risk population segments. All of the hospitals have developed very significant care coordination capabilities working on the inside of the hospital, and we see now the beginnings of care coordination moving out into our provider offices, so that there is a broader perspective on coordinating care. We also see the development of community-based care coordination, where all of the acute and subacute providers serving a county, for example, are coming together on a monthly basis to sort through how care can be improved, how care can be better coordinated, how emergency department visits can be reduced by bringing to bear home care or other opportunities for the patients affected. Certainly, we need to look at integrated primary care and behavioral health, having a greater representation of that. But we also know that there are other integrations of medical specialties that we haven't really defined well yet that probably can benefit our population and reduce the number of exposures that a patient may need to come into an office or to have their care be less fragmented. Patient engagement and activation skills, patient activation skills are needed. All of the critical access hospitals in New Hampshire are moving ahead with patient and family engagement efforts. We're looking at those skills being very important because an engaged and activated patient is going to make better use of the services that are available under the capitated model. And again, we need actuarial support. Threats from the model, clearly no new market share potential and ultimately less money in the system. Again, as I said, the current status is that we have not been presented with this model yet at the level of critical access hospitals. We have the National Rural Health ACO model operational now with 6 of our hospitals, but that has only an upside potential, and I think they are now 10 months into that model. And if any of them are on the line, they may have some additional comments.
Do we have anybody on the line?
Yes, I'm on the line. Josephine from Murray Center. Hello?
So, yeah, no, I was just asking if there was anybody from the National Rural Health ACO group. Yeah.
We may not have them on.
Yeah, that's understandable.
Beyond today. But anyway, that's the way we're looking at full cap right at the moment.
No, I think you bring up a lot of really interesting issues, and I think another area where we see groups other than the integrated behavioral health and primary care, where we see groups starting to try to create some collaboration around is the area of clinical pharmacy. I just wanted to share that also because I think that's another area where we're starting to see some innovation, and with the shifting of some of the payment models, it makes implementing that model, that sort of strategy a a little bit easier. The other thing I wanted to, oh, go ahead, sorry.
No, I would agree with that, and I think that it is important, and it needs to be reinforced that clinical pharmacy is one area where savings can materialize rather quickly. If we're really doing an aggressive job with medication reconciliation, not just determining that we know exactly what medications the patient is on, but is it the optimal mix of medications? And we can hopefully make improvements and save on the total expenditure for pharmaceuticals very quickly. So that's a return to the system that can happen much faster than say, reducing the overall cost to provide inpatient care.
Right. Right. No, I appreciate that perspective. The other issue that I want to raise, and I swear to God, I don't want to have us tackle this on a Monday morning of a holiday week, but this whole idea, I was just at another meeting on Friday where the issue of fully functional integrated HIEs came up. And I think that there is a lot of emphasis, I think, in all of these models, even with pay for performance, that really rely on strong functioning HIEs. And our experience working around the country has been that this is an area that safety net providers and probably non-safety net providers as well feel a little held captive by what, the level of, capacity that their regional or statewide HIEs actually bring to bear. I think, just from our perspective, a lot of, sort of federal resources and state level resources have been directed at developing these HIE platforms and programs. And I think it's been a huge challenge for the safety net in trying to effectively engage with them in a way that really allows them access to the data, both for the purposes of being able to benchmark performance, but also being able to support proper care coordination. So I would anticipate that if I was to ask you guys how many folks on the line were frustrated with their regional or statewide HIE efforts, that there would be a fair number of hands that went up. And I think this is just an area where we have to continuously work together as a group of safety net organizations in your state and in your regions, where you're really putting pressure on getting these things fully functional. It is too much is predicated on their ability to be able to perform and deliver on the promises that were made. And I think all of you have touched on how important, that capacity is. So at the risk of opening up a Pandora's box, does anybody have examples of that functionality working particularly well, or strategies for trying to coordinate and advocate for providers who are trying to access that might be worth sharing with the group? So does that silence mean that nobody has good examples of it working well?
This is Darcy in Maine. I wish that my QI director was here, actually, and my HCCN director, because they have both been working with our HIE, and we actually have one of the more successful ones in the country. Again, this is Maine. And so I'm not going to be able to speak to details other than to tell you that the health centers who are in our health center control network, which is essentially a network meant to leverage HIT and especially the EHR platforms in the health centers. We've been working diligently with the Health Information Exchange for a couple of years, trying to get a bidirectional interface. And I will tell you the first obstacle for our health centers was cost. So while there have been enormous investments in health centers and other safety net providers around EHRs, none of those investments even touched the inordinate cost to actually first getting connected. So we, as the Primary Care Association / HCCN, helped to really subsidize the cost of those initial connections. And the health centers that are using them have reported back to us, with maybe a couple of exceptions, that they're exceptionally useful. And there are a couple of our health centers in our state working around risk stratification with our HIE, and that project has just gotten underway. So I don't have any results to report, but it's definitely conversations that we're having with our HIE.
No, that's great to know that there's been, really a concentrated effort to really engage with the safety net on that. And I know that my fellow Starlings on the line, we've all run into this challenge. One is the cost of the interfacing, but then also just given the diversity of systems that these HIEs need to interact with. We're seeing some areas where hospital systems are sort of taking on that responsibility. If they've got sort of, the predominant market share in their region, trying to essentially coax folks away from, the regional or statewide HIE to just use the hospital system's HIE. I guess I wanted to raise it just because maybe I'm still smarting from a meeting on Friday where we were talking about this being a challenge yet again, but I do think it's a really important piece of the puzzle, and it's one that we don't necessarily have direct control over. And I think, insofar as we've got good examples of how to support that and make sure that the safety net stays at the table so that our issues related to data exchange and interface, remain part of the agenda as those infrastructures are getting, fully implemented. I think it's really important. Sam or Andy, anything you want to add on that?
No, nothing here.
Okay. Okay, so I forgot to include a slide for global payments. So I want to talk about global payments, and then we're going to go back and revisit the topic on the pay for performance. So are the folks on the line who were assigned global payments, can you guys, I just put the general discussion questions up, can you guys introduce yourselves and let us know how you approached this particular topic?
Hi, this is Misty from Piedmont Health. How are you?
Good. Good morning.
Good. So I do want to say that we changed ours up a little bit. We actually decided to go with partial capitation. I hope that's okay.
Sure, that's fine.
Okay. Well, the first thing I'll probably just start with is just to talk a little bit about kind of the model of partial capitation that we were thinking of. So we were kind of thinking of just the Medicaid population being very broad in that population. And then for the partial capitation to include medical, dental, pharmacy, behavioral health, lab, some outpatient specialties such as cardiology, dermatology, but us also just being responsible for some inpatient metrics such as ER utilization as well as timely follow-up after ED visit and readmission data as well, metrics as well. And so, one of the reasons why we actually decided to move from a global payment system to a partial capitation is just because of really our strengths. We currently have a full capitation model using PACE, the PACE model, which I think some of you on the phone are familiar with PACE. But then we at least have some infrastructure in place. I can't necessarily say we are 100% where we want to be, but we do have an infrastructure of care management that's in place at most of our sites. We have an infrastructure of behavioral health increasingly at more of our sites, as well as dental. At least half of our sites have access to dental. And then we also, our model has always been to have pharmacy kind of at most of our locations. So we kind of moved to that just because of our strengths and realizing that we had some of that infrastructure in place. But some of our weaknesses are, just being able to still, while we have that infrastructure in place, I think we still have a ways to go, particularly around looking at the total cost of care and how you get that data, as well as total utilization. So we can get total utilization for some populations, but not all. And particularly with the Medicaid population, we really can't get total utilization data for that particular population. So that's still kind of one of our weaknesses, is just kind of that infrastructure, sophisticated infrastructure that still needs to be evolved. I think some opportunity, and then just some other things is just continuing to kind of build on our staffing model. So we started off with care management, which is really, it kind of morphed. It started off probably as kind of a social work model. They were doing some behavioral health. And now that we've added behavioral health clinicians on board, and we're also starting to add another layer of RN care management on board, I think we continue to kind of evolve that model over time. But just some other things that we would want to include in the model has been just looking at alternative touches to patients and other ways in which they can use the system outside of using the ED. So really kind of focusing on access beyond just traditional hours, particularly by phone, to avoid avoidable ED visits. And then just what additional competency and infrastructure, and I would continue to just iterate just the need for a data platform to be able to capture utilization, not only kind of what we do with the patient, but what the patient may do outside of our walls, so that we can be able to see the full scope of what's going on with the patient. Some other just data needs as we're just thinking about the model has been kind of like, if you put it in a couple of buckets, it's volume, utilization volume, visit volume, and then, of course, revenue. So wanting to know like the median number of visits for very different groups of population within the Medicaid population. That can be by diagnosis code, also by age. And then really understanding the patients that are attributed to us and having that information on a consistent basis. And then understanding, of course, how they get attributed to us. Understanding the existing cost per patient by service, as well as visit per member per year. And then just being able to, have a method in which we are looking at risk. So taking the pool of population and being able to assess what's the risk level of individuals, and then altering kind of the care and the supplemental care that we give for patients. And then just the average cost per head, and then the factors that contributed to that cost, particularly those that are high utilizers and high cost individuals. I think that's mainly it.
No, I think that's great. Any questions from folks? So Andy, why don't you just do a quick recap of global payments, and we'll loop back to P4P, and we'll close out then with just a quick reminder and an overview of your final presentation stuff for the final session.
Sure. I'll just spend a real quick minute on Amanda. So global payments, sometimes referred to as bundled payments, differ a little bit from partial capitation in that they typically refer to a set of services and the payment pays for those services over a very finite period of time. So unlike a partial capitation, which might look at a whole population and might essentially be the ongoing payment methodology. For example, we'll give you $2,500 a year to manage the imaging needs of this population each and every year. A global or bundled payment tends to look at a specific episode and then define for that episode the set of care options needed for that bundle. The two examples I like to use, one I think is highly relevant to safety net, is a bundle or global payment for all prenatal care and the delivery. But another example I like to use, which I think is certainly relevant to safety net, but albeit not as much of a Medicaid issue, more of a Medicare issue, is a bundle for the hospitalization and 6 months of follow-up care for congestive heart failure. And these are kind of classic bundles in that they've been in use, they've demonstrated an ability to drive certain outcomes and cost improvements because they increase, essentially the flexibility with which the group kind of approaches the patient population. I'll spend a little bit more time on the congestive heart failure one, but generally speaking, the success under a model like that is really all about reducing readmissions, because if you're bearing the cost of those readmissions within a 6-month period, every time you prevent an unnecessary readmission, you're cutting anywhere from $5,000 to $25,000 out of the budget that you're expected to manage. And typically they're benchmarked to a certain readmission rate that would be considered desirable, but where the group had been, essentially underperforming. So, for example, if 40% of all patients have historically been readmitted, you might have a different cost profile than if 25% had been readmitted within 6 months. And so the bundle would be set, the payment level would be set such that it was less than the 40% and really kind of drove focus of performance to bringing that readmission rate down to the 25%. And that's in essence where the savings come from. And that in essence is defined financial opportunities for the provider. From a financial management standpoint, I think it does incent a lot of the same behaviors, which are data, understanding historical utilization, identifying and activating patients, and from a risk standpoint, I think are typically fairly significant financial risks because in theory they are unbound on the top end, meaning you could have fairly unlimited cost overruns. But because they're defined so discreetly for such a small set of episodes, might be a decent area for safety net providers to consider some testing because it's not, unlike, partial capitation, full capitation, which typically looks at whole populations, this looks at much, bundles typically look at a much smaller set of the population. One last thing from a financial standpoint I'd indicate is when you enter into bundles or global payment arrangements, you don't necessarily know going in how many patients you'll have that trip that bundle or that episode. You may be able to do some prediction of what that might be based on historical trends, but you could end up with 10 cases, you could end up with 1,000 cases. It really depends essentially how things shake out that particular year. But that's, Amanda, that's kind of the model in a nutshell, and we just wanted to make sure we covered that one as well. Back to you, Amanda.
Thanks, Andy. Any questions on global or bundled payment? Because this is one we know that sometimes can be a little confusing for folks. Okay, well, let's come quickly back to pay for performance before we just wrap it up with a brief discussion about the case study or the final project assignments. Are you guys ready to go on this one?
Sure. Thank you again for your flexibility. I appreciate it. So we had a pretty wide-ranging conversation here with my team. So I would say that our QI director here has the most experience in terms of one-to-one understanding of what some of the primary care practices he's worked with on the hospital side and now with the FQHCs. But generally, pay for performance has been around with our health centers. So we as the PCA obviously don't provide direct service. So this is just based on our observations over the last couple of years. And I've been here about 10 years. So I know that pay for performance has been available to our health centers for probably about 10 years. We've had, as in any big reform effort, we've had some early adopters. And then I would say the majority of our health centers now are involved pretty much on the commercial payer side with one or more initiative that tends to focus on either one or more chronic disease states. There really is, so yes, we've been presented with the model, and it was presented primarily through I think through the commercial payers deciding that they wanted to see some movement, particularly in performance measurement for specific chronic diseases. A question that we've always had is whether or not the emphasis, so whatever the health centers are negotiating with the commercial payers in particular, whether or not those are having a high economic impact in terms of driving down costs. That's never really been clear to us. So I think that's potentially one of the limitations if this narrow focus, and I should say that we at least came to the conclusion in our discussion that pay for performance is a pretty narrow focus in terms of reform, and that it might sort of whet the appetite or get people ready at the health centers for doing more, but it's certainly not as expansive of a population health management tool as a lot of the other models that we've been talking about. Typically, the pay for performance has performance measurement, some kind of incentive design. In most cases, what we've heard is that it's, again, focused on a chronic disease, and there may be an enhanced payment in, above and beyond whatever the fee-for-service payment is. And there are some established benchmarks that the health centers have to report out on relative to those conditions. And then one element that we thought was probably, at least in what we've observed with the pay for performance, a missing element, but is included typically as part of the kind of the three areas, is more transparency and consumer engagement. So we do have an effort in Maine to do reporting on individual provider quality. And the website, I believe, is called Get Better Maine. But one of the things we noted in our conversation I felt was kind of missing in that side of the house was patient activation and the ability for, in this case, our FQHCs to really move a certain patient toward health if he or she were not activated. So you guys are all probably familiar with patient activation, and that's something that we definitely feel like in a pay for performance is not maybe necessary, but would be really interesting to see if it could even push the dial further. I guess we didn't find this model particularly threatening. Again, there's very minimal risk, at least in the models that our health centers are participating in that we're aware of. The opportunities that I think the models present are to do a deep focus. So if you do have a preponderance of diabetes or hypertension or other chronic diseases that are high cost, it does give you an opportunity to really do outreach, to really focus on those patients and hopefully move outcomes in the right direction, which is always a good entree to then hopefully addressing health in a more holistic way. I would say some of the challenges are the challenges that you'll find in any model, which is workforce retention and recruitment. So it's really hard to do any kind of payment reform activity if you have staff turnover. And like every other, I think, safety net site in the country, we really struggle with staff turnover and recruitment and retention of good team players, in part because a lot of them feel exhausted by all of the payment reform change and challenges. And then we talked a little bit about in other presentations about the reliability of information exchange, both within a health center but also without the health center. So how do we know how much of the patient's outcome we're touching as the primary care provider versus all the other specialists and other folks that might be involved in someone's care? And that's a challenge, I think, even for a pay for performance. I think one of the big limitations that we identified was that a pay-for-performance model doesn't necessarily promote systems thinking or systems-based operations. Typically, when you're looking at a disease state, you sort of assign a project, or it's more project-focused, rather than where each project essentially is aimed at improving a discrete process or outcome. And there may be some limitations to how long that can be sustained if it's not in a systems kind of approach. So that's why we felt like this model probably had some pretty significant limitations in terms of being able to really push toward population health in a meaningful way. I would say the strengths that our health centers have in dealing with this model, though, is that they have a longstanding focus on quality and chronic disease management because they have those UDS measures for which they're responsible. So it's not a huge leap for them necessarily to do that work. And the majority of health centers here are patient-centered medical home recognized, and that has really helped to improve some of the outreach strategies to hopefully get back to some of that more meaningful patient engagement that helps to drive chronic disease management and minimize some of those risks. But overall, we basically came to the conclusion that this is kind of like the first step in a much broader journey, and that we anticipate that health centers and most safety net providers are probably doing this, but doing a lot more just because they recognize some of these limitations themselves. And I think I got everything in our conversation. It was a little bit all over the place, but thank you again for your flexibility. I appreciate it.
No problem. And I think that, I think you hit a lot of the important issues. And I think, the primary one being that this is a model that a lot of us are familiar with. We realize some of the skills and competencies that we have and have already been employing in order to leverage this, but this isn't one that's likely to exist on its own for much longer because it really doesn't push that needle around payment reform, but it is a really good transitional model. So just a quick reminder, our last session is on December 5th, and we during that session we're going to be hearing from you guys, each of your groups, about your final presentations. Kind of your roles and responsibility as it relates to that are to make sure that you meet internally as a team to discuss and answer the questions that are posed within the slide deck and the directions for the final project. We've met with many of you individually already just to talk through some of the issues that have cropped up as you've been thinking through this. If anybody wants to meet with Starling again as you're finalizing that, feel free to reach out to any of the Starlings via email, so Andy, Samantha, or myself, and we're happy to schedule a quick check-in call. Please use the PowerPoint slide deck that's provided to you, and AJ's got it included in today's session. And in order for us to be organized and ready for that last session, if you could have your slide deck available to and submitted to Samantha at the email address that's identified here. That's Samantha's email address. During your discussion to the group, you're going to be talking about the value-based payment models that are most appropriate for your organization at this time. Which areas of that value equation that we presented back in the early sessions do you think are really the ones that you're going to target through your value-based payment readiness work? And what are some of the key investments that you see in order to really maximize your ability to leverage that model? What are the barriers that you see, and how will you address those barriers? And then what kind of options do you have to address those barriers? So it's going to, most of you guys have done this already. You've provided a 5-minute, you're going to be provided a 5-minute presentation using the attached template. It says here your organizational schedule 30-minute meeting with Starling advisors, but actually, like I said, most folks have already done that. If for some reason you want to have a follow-up meeting, let us know. We'll get it scheduled the week of the 28th. This is the order of the presentations on December 5th, just so you know kind of when you're up in the session. So, but again, the big thing is just make sure if you need any help as you're going through the exercise, reach out to us between now and the week of the 28th. We'll get something set up. Make sure to submit your presentations to Samantha by the 30th. And I think with that, are there any questions about the final presentation? Okay, great. Well, with that, we're going to let everybody go, and hopefully everybody is going to have a safe and sane and relaxing Thanksgiving, and we will talk to you in a couple weeks.